Good morning. I'm Dr. Kirihena, consultant ENT surgeon attached to the National Hospital of Sri Lanka. Today I'm going to talk about diseases of the pharynx. Pharynx can be divided into three parts, very clear boundaries. The top part is called the nasopharynx, it is marked in red here, which is basically behind the soft palate and underneath the skull base. It's bounded laterally by the eustachian tube. Then oropharynx is the next level. Laryngopharynx is the lowest part. Oropharynx will consist of the soft palate, anterior and posterior tonsillar pillars, and the tongue base, the posterior pharyngeal wall. Laryngopharynx would be the rest of the piriform sinuses and everything about the larynx. This is the anatomy of the pharynx. Look at the bottom of the picture. Trachea can be identified in front and behind the esophagus. At the top part, there's a muscle here called the cleptopharyngeus muscle. And this is the inferior, the entire thing is called the inferior constrictor muscle. It's attached to the cricoid cartilage as well as the thyroid cartilage. And on top here is the superior constrictor muscles. Underneath this would be the tonsils. And in the middle here, you see the hyoid bone, and to that would be attached the hyoglossus muscles and the mylohyoid muscle, all going to the tongue. This is the anterior biliary digastric and the tendon. Posterior biliary digastric has been cut to show the other muscles deeper to that. Here the styloid process coming from the skull base, and there are some muscles and a ligament attached to that. Stylohyoid ligament going to the hyoid bone, and the muscles are styloglossus muscle can be seen here. This is a cross section of the head showing the tongue. So this is the tongue base, this is the soft palate. So all this area is all up to the vallicular oropharynx. And above the soft palate, behind the nose, in front of the skull base is the nasopharynx. This is the eustachian tube opening. This is the epiglottis. So this is the anterior arch of the cricoid cartilage, which is shorter in height, and this is the posterior arch of the cricoid cartilage, which has a greater height than the anterior arch. And this is the thyroid cartilage, which is a V-shaped cartilage, so you don't see a part behind here. Vocal cords are at that level. Posterior is attached to the cricoid cartilage, the retinoid, basically retinoid cartilage on the cricoid, and anterior to the thyroid cartilage. So above the vocal cords is the ventricle, a space called ventricle, and then the false vocal cords will be above that, and all that is supraglottic area. Subglottic area would be area underneath the vocal cords up to the end of the cricoid cartilage. This is the X-ray neck lateral view in the vertebral column, and in front of that the prevertebral tissue and the esophagus, and there's a trachea in front. Larynx would be in this part, and you can recognize the epiglottis in this area. And this is the hyoid bone. This is the tongue base, the lower border of the mandible. I would like you to appreciate the fact that the prevertebral tissues, the thickness, the horizontal thickness, is less than the diameter of the vertebral thickness. So the condition that affects the nasopharynx, there are congenital conditions called atresia or stenosis. Atresia means the opening is not there. So the posterior nasal aperture has not developed, it is tenuous or closed off. It's called choanal atresia, which can be one-sided or on both sides. We will be discussing about adenoids. It's an lymphoid tissue that grows in the nasopharynx, a common problem in the 3 to 6 year age group. And nasopharyngeal malignancies, which is very rare in this country. Squamous cell carcinomas in the nasopharynx is very common among the South Chinese people. Lymphomas can happen at any age in the nasopharynx. And rhabdomyosarcomas are commonly seen in the pediatric age group. This is a picture of a CT scan, axial section, showing the choanal atresia on one side. You can see the patent posterior nasal aperture on this side. On this side, the aperture is closed in this area, partly by a membranous wall and partly by encroachment of the bony wall into the posterior nasal aperture. So this is a case of unilateral choanal atresia. And in front of that, there is opacity because the normal nasal secretions cannot go into the pharynx. They collect here. So this is the collected secretions. An endoscopic view, when you pass the endoscope, there will be a lot of secretions in the nose, but once you have sucked out the secretions, this will be the appearance. This is the appearance looking from the nasopharynx side. So the and you can see the other side normal opening, and this side the opening is closed. In bilateral choanal atresia, you can see the both openings are closed off. And sagittal section shows a thick bony wall in that area. Choanal atresia may be associated with CHARGE syndrome. CHARGE stands for other anomalies like coloboma in the eye, heart disease, choanal atresia, mental retardation, genital abnormalities, and ear anomalies. They may also, and it may also be associated with cleft palate. How do we diagnose this choanal atresia? So when a baby is born and is rooting to pass the NG tube into the pharynx through the nose. And if there's failing to pass the NG tube into the pharynx, then we suspect whether there's atresia. In later life, unilateral choanal atresia can present as unilateral nasal discharge. It can go undiagnosed for a few years, if not carefully examined. But bilateral choanal atresia, where both nasal apertures are closed off, it will be quite apparent in the newborn period. On the day one itself, it will be apparent. So this baby will be cyanosed when sleeping and also during breastfeeding. But when the baby opens the mouth for crying, the cyanosis will disappear because the child is breathing through the mouth. Babies are obligatory nasal breathers, so they don't know how to breathe through the mouth when the nose is closed off like this. So they will be cyanosed when they are sleeping. The nasal endoscopy, we will be able to diagnose this with the nasal endoscopy. And CT scan paranasal sinuses, the pictures we have seen before, would confirm the diagnosis. Both axial and sagittal views would help in making the diagnosis. And it will also identify whether the bony wall of the atretic plate, whether it's membranous or whether it's bone and membrane, or both are there. Treatment for bilateral choanal atresia is immediate surgery. So until the surgery is done, the pediatricians will put oropharyngeal airway and then to avoid the cyanosis. And within a day or two, the ENT surgeon has to go in and do a surgery. So we basically can open up the atretic plate. I prefer to do it endoscopically, where there are other techniques of doing that as well. In the case of single-sided choanal atresia, where the other side is patent, there is no threat to life, there is no cyanosis, so we can wait when the child is bigger and has a larger body weight to operate. So maybe 1 to 4 years would be an ideal time to operate. The only problem they will have until the surgery is done would be a unilateral nasal discharge. The other condition affecting the nasopharynx would be the adenoids. This is commonly seen in 2 to 6 year age group, and you can identify it on the X-ray like this. If you look at the cross section from the skull base here to the soft palate in this area, you can see how the adenoids will reduce the space available for breathing. In this case, almost by 50%. Endoscope. When an endoscope is passed into the nasopharynx through the nasal cavity, adenoid will appear like this, the swelling coming from the posterior wall of the nasopharynx. Sometimes it can be totally blocking the choanal. It's very close to the eustachian tube opening, the enlargement. So there's a possibility that because of that enlargement, eustachian tube ventilation might get affected. It will also act as a source of infection to the eustachian tube and may give rise to recurrent miliary infections as well. So how do they present? Adenoid enlargement will present with the symptoms of blocked nose, or they have rhinorrhea throughout the day, most parts of the day a week. It's a kind of cold that never settles. And because their nose is blocked, they will be breathing through the mouth. And sometimes when the obstruction is severe, they might be snoring. And in those cases, they may be having obstructed breathing, so they may not be breathing at certain times in the night. So that's called sleep apnea. Because the adenoid can act as a source of infection, and also it can mechanically compress the eustachian tube opening, it can give rise to recurrent otitis media and less middle ear effusion, so what's called a blue ear. So they might present with a hearing impairment, a conductive hearing impairment due to the blue effusion in the middle ear. So if you don't treat it early, if they continue to breathe with the mouth open, this is what will happen in the long term. The facial skeletal growth can get affected. So this is what is called adenoid facies. So they have an open mouth posture. And in the long term, there can be flattening of the nasal bridge area and high arch palate. And they might develop a short upper lip and a long face. So if the mouth breathing goes on for so many years, the facial skeletal structure can get affected permanently. And they might end up with dental problems when they're 16 years due to the hyperplasia of the maxilla. So these are the features of adenoidal facies: open mouth, prominent incisors, short upper lip, elevated nostrils, hyperplasia of the maxilla. So this is what causes the dental problem at the age of 16 years. High arch palate, elongated appearance of the face. So if one needs to avoid this kind of a structural deformity of the face, one has to go and remove the adenoids at an early stage. A diagnosis of adenoidal enlargement can be made clinically, confirmed by examining the postnasal space with a mirror or posterior rhinoscopy, and also be diagnosed with X-ray postnasal space and non-nasal endoscopy. And what is the treatment? Since the adenoid is the lymphoid tissue that get enlarged with each common cold, but after the cold settles, it doesn't shrink back to the original size. So with each cold, there will be progressive enlargement from 2 to 5 years age, and by 5 to 6 years, they will have massive enlargement of adenoids. So we can try medical treatment. Saline irrigation of the nose, short-term decongestion use up to 2 weeks, and steroid nasal drops or sprays for 2 to 3 months. Antibiotics can be given to control the associated sinusitis. Antihistamines can be given if they have allergic rhinitis symptoms. Short course of oral steroids can also be given. After trying the medical treatment for 3 months, if there is no significant improvement, or if they relapse after stopping the medical treatment, then there is a place for surgery. So surgery would be adenoidectomy, and if they have a middle effusion, that has to be removed as well. It's called myringotomy. Sometimes grommet insertions are also done. This is a picture of adenoid curette that is traditionally used to remove the adenoids. The adenoids are removed not through the nose, but it's removed via the oral cavity, transorally. It's too big to be taken out of the nostrils. Adenoid problems are common in the nasopharynx, but nasopharyngeal carcinomas are uncommon in this country, but still we do occasionally see occasional case. So this is an endoscopic appearance of a nasopharyngeal carcinoma. Unlike the adenoid which comes in the midline, in this nasopharyngeal carcinoma generally come on a side, compressing the eustachian tube. So their symptoms may be due to compression of the eustachian tube. They might present as a middle ear effusion and deafness, or it may be due to enlargement causing nasal obstruction, or because of the tumor growing rapidly, it might bleed into the nose or throat. So that's how it will present. Or because it's a high lymphatic supply in this area, they might present with the enlargement of lymph nodes, especially in the posterior triangle of the neck. Lymphomas can also happen in the nasopharynx, but it will have a smoother swelling, might grow into the nose and also erode into the skull base posterior. You see the appearance of a lymphoma, smooth swelling, the nasal septum and infinite vein, so lymphoma going into the nasal cavity. Need the CT scan showing the maxillary sinuses here, the nasal cavity here, and the posterior end of the septum, and all that is the tumor. So it turned out to be nasopharyngeal carcinoma on biopsy, and you can see there's erosion of the skull base also. Because the skull base is eroded, nasopharyngeal carcinomas can also present with cranial nerve palsies, because cranial nerve that exits the skull base can get affected. This is a picture of a lymphoma on one side. You can see the lymphoma growing into the nasal cavity. This is a picture of a glue ear, or what we call middle ear effusion. You can see this is the eardrum on otoscopic endoscopic examination. This is the handle of the malleus. The lateral process of the handle of the malleus appears prominent because the eardrum is retracted due to the negative pressure in the middle ear. And you can see bubbles due to the fluid and air getting mixed up. And they generally present with a mild hearing impairment due to the conductive nature of the hearing loss. So this is another way nasopharyngeal malignancy can present: massive enlargement of the posterior triangle lymph nodes. On endoscopy will show a small tumor in the nasopharynx which bleeds, but there's a massive neck enlargement. So squamous cell carcinomas or lymphomas can present with due to obstructive symptoms like hyponasal voice or nasal obstruction, bleeding into the nose and throat, cervical lymphadenopathy, or they can present with lateral middle ear effusion and hearing impairment. There can be cranial nerve palsy due to the intracranial spread. Since the nasopharyngeal carcinomas are so common in the South Chinese people, if a Chinese person in that region comes with a middle ear effusion in one ear, they assume it's a nasopharyngeal carcinoma until proven otherwise. CT scan will confirm the diagnosis, the spread of the disease, and we have to take a biopsy to confirm the histological diagnosis. And if it's a nasopharyngeal carcinoma, the treatment would be radiotherapy and chemotherapy. Surgery doesn't have much of a place in clearing the disease. This is quite an innocent condition in the nasopharynx called it's a cyst called thorn wall cyst. It's embryological remnant. This cyst appears. So they might present with, if the cyst is big enough, it might present with nasal obstruction or hyponasal voice. Treatment is surgical excision. In this patient, when the mouth is open, you can see there's a white polyp there. It's actually coming behind the soft palate. This is the soft palate. Origin is not in the oropharynx, although we see it in the oropharynx. It's actually coming from the maxillary sinus, growing into the nasal cavity and extending into the choana, and then hanging down from the nasopharynx into the oropharynx. So it's called antrochoanal polyp. Antrum is maxillary sinus, choana is nasopharynx, but as it grows, enlarges posteriorly, it can hang down from the oropharynx. Symptoms would be that of nasal obstruction and change in voice due to the nasal passage being blocked. Treatment is surgery. These are the equipment that we use to examine the nasopharynx. This is the traditional post-nasal space mirror is different from the laryngeal mirror. It has a bend like this. So you have to put it through the oral cavity with the tongue depressor and ask the patient to breathe through the nose while so the soft palate hangs down. The soft palate is relaxed, you can look into the nasopharynx. So it's a bit difficult sometimes for the patient to relax. So nasal endoscopy pass through the nasal cavity will avoid all the problems of examining the nasopharynx. The oropharynx. The problems affecting the oropharynx would be the cleft lip and problems which are congenital, tonsil problems, lingual thyroids, and malignancies, neoplasias of the tongue base, valvular fossa, tonsils, and palate. This is a child with a cleft palate, congenital problem. And when you look into the mouth, you see a big cleft in the hard palate and soft palate, and you can see the nasal cavity through this. And this is the nasal septum. These are the turbinates on either side. So the problem with cleft lip and palate will be the difficulty in sucking and the speech problem. So if the cleft lip has to be repaired early for feeding, for speech development should be repaired at least by 12 months of age. This is the appearance of the tonsils, large tonsil. It's a tonsil on the other side, and the uvula here. This is the tongue. This kind of person can present with snoring due to the enlarged tonsils. This is the appearance of infected and enlarged tonsils, pustular tonsillitis. You can see a lot of pus on the tonsils, and tonsils are also enlarged. They generally present with fever, so severe sore throat, painful swallowing, sometimes with cervical lymph node enlargement. This is a tonsillar cyst. So sometimes the patients open their mouth and then they notice this cyst on the tonsil and they get a bit worried with it's a malignancy, but it's an innocent condition. It can be removed surgically if required. So this oropharyngeal picture showing a distorted anatomy. Uvula is pushed to a side, and destruction of tissues is this is a malignancy, tonsillar malignancy. This is the external lateral view showing what is called styloid process. You see the styloid process, elongated styloid process. This is due to the calcification of the stylohyoid ligament going to the hyoid bone. So because the styloid process is elongated and it can project medially through the tonsil, they might present with tonsillar pain on one side, and also they might present with an earache. Treatment is surgical excision. You have to go through the tonsillar bed and remove the styloid process. So tonsils problems can be recurrent infections called tonsillitis, then the enlargement which might cause snoring. There's a high chance of tonsils getting enlarged in children if they are breathing in the mouth open due to adenoid enlargement. So adenoid will cause nasal obstruction, and at the time when they breathe with the mouth open because the nose is blocked, the tonsils will also get enlarged and then cause oropharyngeal obstruction. So snoring becomes worse, especially in 4 to 5, 6 year age group children. Tonsils may have innocent cyst like I have shown. Then keratosis, that's like white debris developing on the tonsillar crypts. And TB can happen in the tonsils. Malignancies can also happen, squamous cell carcinomas. And if there's a smooth enlargement of tonsil on one side, think of a lymphoma. What are the features of tonsillitis? They will complain of pain in the throat, fever, painful swallowing, nausea and vomiting, sometimes abdominal pain. Examination, they might be dehydrated because they are not taking adequate amount of water due to the pain. They might have enlarged neck nodes, and tonsils might look inflamed and enlarged as well. It need not always be enlarged, it can be just inflamed only. You might also say pooling of saliva because they are unable to swallow properly. Tonsillitis can heal without complications, but it can also give rise to complications. So infections can spread beyond the tonsillar capsule and form an abscess, between the tonsillar capsule and the superior constrictor muscle called peritonsillar abscess. So then they might, because superior constrictor muscle is inflamed, they might find difficult to open the mouth. So they end up with trismus. So they are not able to open the mouth fully. Infection can spread down and cause laryngitis and pharyngitis. Systemic complications of tonsillitis was very common few decades ago, but not so common now due to the widespread use of antibiotics. Rheumatic fever and rheumatic valvular disease used to be very common following recurrent acute tonsillitis. Acute glomerular nephritis can happen. Both these conditions are immune-mediated problems. Meningitis can happen. Pneumonia and septicemia can also happen with tonsillitis. So this is a picture showing a peritonsillar abscess. You can see the soft palate here. You can recognize the uvula, which is pushed to the other side, normal side, and the tonsil, left tonsil is enlarged, and above the tonsil there's a bulging on the soft palate. We see the appearance of the peritonsillar abscess that happens when the infection spreads from the tonsils and cause an abscess between the tonsillar capsule and the superior constrictor muscle. And they will also have trismus, difficulty in opening the mouth. Treatment is you just have to make the incision in the bulging part here under local anesthesia with the patient seated, and then drain the abscess, which might be called deep seated. The treatment of tonsillitis is antibiotics, pain analgesics, mouthwashes, can give antiemetics if there is vomiting. If they can't take by mouth, can give IV fluids. If the abscess are developed with trismus, we can do the INT for the peritonsillar abscess. And surgical treatment can be considered when indicated. For the cyst, cauterization can be considered. There are very clear-cut guidelines for tonsillectomy surgery. It's a painful surgery, and they will have pain for about 5 to 10 days after surgery. And there are also complications following surgery, like bleeding, which can be sometimes life-threatening occasionally. So therefore, we have to select the cases very carefully. So if the disease is worse than the complications of surgery, then it's better to offer the surgery. So if they have more than 6 episodes of tonsillitis, each episode confirmed by a GP at least, and it's 6 episodes for a year, for at least more than 2 years, then it's justified to do a tonsillectomy. If they have had 2 episodes of peritonsillar abscess, then we go and remove the tonsil. Suspected malignancy, if there's irregular growth or a lateral enlargement, then we suspect malignancy, we remove the entire tonsil and then send it for histology. And if the tonsils are both enlarged and to cause sleep apnea or snoring, then tonsils have to be removed. In children, the snoring is cured simply by removing the enlarged tonsils and by removing the enlarged adenoids. If the patient have a benign cyst on the tonsil or they have keratosis causing halitosis, tonsillectomy can be considered, but it is not absolutely essential. Sometimes we remove the tonsil to access the styloid process. So in the case of enlarged, elongated styloid process causing pain and ear pain and throat pain, we remove the tonsil first, go through the superior constrictor muscles and dissect all the attachments in the styloid process before we can dissect it off the skull base and remove it. In the case of bronchial fistula, it's an opening that you see in the neck. When the surgery is done and the tract is followed up into the throat, the opening, the upper end will be in the tonsil. Sometimes the tonsil may have to be removed to complete the surgery. What are the contraindications of a tonsillectomy? If they have acute infection, they have bleeding disorders, and those who are unfit for general anesthesia will be unfit for surgery. What are the complications of a tonsillectomy? During surgery, there can be hemorrhage. We might need to control it either with bipolar diathermy or by ligages. Aspiration of blood can happen into the throat. So it has to be avoided by keeping a throat pack covering the laryngeal inlet before we start the surgery. And surgery done with the mouth open using a metal mouth gag. So when you are inserting the mouth gag, there can be damage to the teeth, lips, or palate. So that needs to be avoided. In the immediate post-op period, on the day of surgery in the night, sometimes the tonsillar bed, which is quite dry, suddenly can start to bleed. And there can be, it's called reactionary hemorrhage. And then if the patient is a bit drowsy, they can also aspirate. So in the post-op period, we prefer to give the patient in a kind of a semi-port position. So if they start to bleed, the blood will come out of the mouth rather than going down into the larynx and getting aspirated. And in a conscious patient might complain of a feeling of a blood clot in the throat when the tonsils start to bleed. So the bleeding, the blood will clot on the tonsillar bed, but there will be continuous hemorrhage underneath the clot. Because the clot keeps the supraconstrictor muscle fiber stretched, and the bleeders that are coming through the muscle fibers will be kept open by the clot. And so the only way to control the bleeding is to remove the clot and put an adrenaline sop into the tonsillar bed so that the muscle can contract and shut down the blood vessels coming through the muscle fibers. Sometimes when the surgeons they go home without any problems, but because of the pain they may not eat or drink properly, and then the tonsillar bed can get infected, and when the stops separate, they can have a secondary hemorrhage. Sometimes the bleeder might open up due to the local trauma by eating hard food like crusty bread, and they might come with profuse bleeding anytime from 7 to 14 days after surgery. So they might need to be admitted, and if there's infection, they have to start on antibiotics, and the bleeding has to be controlled with adrenaline packs, or may have to take to the theater to control the bleeding. Sometimes the tonsillectomy might give rise to speech defects and nasal regurgitation due to the palate not working properly. But this is very rare. And if the tonsil is not completely removed, there can be recurrence of infection due to the remnants, especially close to the tongue base area. So treatment for tonsillar keratosis, where you see lots of white dots on the tonsil, in just throat gargles, manual removal, maybe with a toothbrush the person can remove it himself, or in the halitosis, you might consider doing a tonsillectomy. A cyst on the tonsil, if this patient is asymptomatic, no treatment is required. If infected, antibiotics can be given, and cyst can be removed by cauterization or by doing a tonsillectomy. Malignancies in the tonsil, tonsillectomy can be done. In the case of lymphoma, all you need to do is do a tonsillectomy, send the tonsil for histology. If it is diagnosed as a lymphoma, then you hand over the patient to the oncologist for the rest of the treatment. In case of squamous cell carcinoma, the oncologist might request you to go and do a further surgery like neck dissections and mandibular dissections before they go for radiotherapy and chemotherapy. This is a picture of the oropharynx. You can recognize the tongue, and behind the tongue there's a smooth swelling. This is a lingual thyroid. You can see the epiglottis in that area, and the tonsil on the left side, tonsil on the right side. So most of the time this is asymptomatic, and if they have symptoms, we might consider removing this, but sometimes this might be the only remaining thyroid tissue in the body. So only way to find that out is do an ultrasound scan of the neck and see whether the thyroid gland is in the normal position, and then do a radioisotope scan to see whether the activity of the thyroid gland is normal. So if you have a normal thyroid gland with normal activity in the neck, you can afford to remove this. If not, we will just leave it there for the production of thyroxine. But it is causing symptoms to the patient like difficulty in swallowing or speech problems, then we need to excise this and re-implant it elsewhere in the body. So this size shows the same thing that I've been mentioning. So it's also important to do a thyroid profile when you see a lingual thyroid to see if the thyroid production is normal. And if not normal, we may give thyroxine. If you don't give thyroxine, then that lingual thyroid might enlarge further. Foreign bodies in the throat is a very common problem. The foreign bodies can be stuck on the pharynx, especially on the tonsils, maybe on the vallicular fossa, piriform fossa, or it might enter the esophagus, larynx, trachea, or bronchus. So when a patient can complain of foreign body ingestion in the throat, you must ask the patient, where do you feel the foreign body? Sometimes they might point to the upper part of the throat. So then you just ask them to open the mouth, put a tongue depressor and ask them to say, ah, then everything opens out. Foreign body might be on the tonsil like this. So all you need to do is, using a crocodile forceps, just pull it medially and pull it out. So it's amazing. Sometimes people, if you don't examine the throat with the patient seated in front of you with a good headlight and tongue depressor, you might miss the tonsillar foreign bodies. And this is a foreign body stuck in the laryngeal inlet. You can identify it with the ideal, even indirect laryngoscopy. And for removal, of course, you might need a endoscopic assistance, either flexible endoscopy, or as in this case, there's a metal instrument here we have inserted. We are removing through a direct laryngoscope. Foreign bodies in the piriform sinus. Now, piriform sinus is generally a space that is naturally closed. So you may, to see the piriform sinus, you have to ask the patient to say A, and then it opens out like this. When the patient say A, the cords comes together and the piriform sinus opens out. So if you are lucky, you might be able to remove this with the upper GI endoscope. Otherwise, you might need general anesthesia and rigid endoscopes to remove the foreign body. A coin in the esophagus. A coin in the children commonly swallow coins. So sometimes it's in the post-cricoid region. So when the anesthesia and I give GA, they can remove the coin using the nasal laryngoscope. But if it goes beyond the post-cricoid region into the esophagus, you need general anesthesia, full relaxation with succinylmetonium, and pass the rigid esophagus code, and you can remove the coin. This is actually a lithium battery that is showing here. Coin also appears like that. But lithium batteries are surgical emergencies. You need to go in quickly and remove that, because even a dead battery will have a certain amount of electricity leaking, and the alkaline the discharge might cause erosion of the esophagus and might give rise to serious complications of perforation and even esophageal fistulas. If the foreign body is in the lower esophagus, and if it's a inert thing like a coin, then maybe you can pass upper GI endoscope and try to push it into the stomach. Once it's entered the stomach, it will go down into the intestine without a problem. So the clinical presentation, they give a history of foreign body ingestion during a meal or putting something in the mouth and get it stuck in the throat. They will have pain in the throat, painful swallowing. And late presentation might present with severe pain due to the infection in the soft tissues, neck swelling, if there's abscess forming. Sometimes they have fever and stridor out because of the laryngeal swelling. Occasionally, dry fish bones or penetrating injuries to the pharynx from foreign bodies can cause abscess. It's a picture of retropharyngeal abscess. So they have severe dysphagia, almost drooling or saliva-like, unable to swallow anything. And a CT scan or X-ray lateral view will confirm the diagnosis. And the treatment is surgical drainage. Sometimes we can go transorally and drain it. Sometimes we go externally and drain it. And when the abscess is big like this, now if you look at the vertebral transverse diameter, you can appreciate how wide the transverse diameter in this retropharyngeal space. Normally it should be less than half the diameter of the vertebra, but this is 3-4 times that of the vertebra. So this kind of thing can easily be drained transorally, but if it is bulging in the neck, we can go externally and drain it. Retropharyngeal abscess, the commonest cause is not foreign body. Commonest cause is in children is due to the separation of lymph nodes in the posterior pharyngeal wall due to viral infections. The danger here is that since the surgery has to be done under general anesthesia, if the anesthetist tries to intubate the patient, there's a possibility that they might rupture the abscess and the infected contents might spill into the larynx and trachea and cause aspiration pneumonia. So the anesthetist has to be warned to be careful about intubation, not to traumatize the posterior pharyngeal wall, and if they traumatize, and they should be warned the pus might come out and there's a risk of aspiration. So they will take the necessary precautions to avoid aspiration in case of a rupture of abscess during intubation. So foreign body in the pharynx and esophagus, examination of the mouth and tonsils is important. Then you proceed with the you can use a tongue depressor to examine the mouth and tonsils. Then use a laryngeal mirror to do the indirect laryngoscopy to see whether there's a vallicular foreign body or a piriform sinus or carotid foreign body. X-ray neck lateral view, soft tissue windows, CT scans will be helpful to diagnose. Treatment is by removal. So if the foreign body has entered the esophagus, you might need esophagus scope, either flexible one or a rigid one, depending on the situation. And if the foreign body can occasionally penetrate the pharyngeal surface and might lie in the neck tissues or might lie outside the thoracic esophagus. So in which case we might need a neck exploration or a thoracotomy to remove the foreign body. The problem with foreign bodies in the larynx and bronchus is that you can have choking with ingestion of foreign body. A child who is playing with toys sometimes might put a small part of a toy in the mouth and he might aspirate it when he tries to breathe in, and then he might develop a bout of dry cough. A child who didn't have a cough and a cold, if they develop a bout of cough while playing, then you must have a high index of suspicion of a foreign body inhalation. And if the child has had a cough and a cold, then again there's a higher chance of aspiration of a foreign body that is kept in the mouth. It is small enough to go through the vocal cords. If the foreign body is blocking a main bronchus, then you might notice there's diminished air entry. But sometimes the foreign body might be there in a distal bronchus without any physical signs in the lungs. Chest X-ray might show either collapsed lung or a more emphysematous lung if the main bronchus is blocked. And if that is inconclusive, we can order CT scan of the chest to see the foreign body. Treatment is you have to either perform a laryngoscopy and a bronchoscopy to see the foreign body and retrieve it. Trauma to the pharynx can happen in association with laryngeal trauma or alone. Commonly due to road traffic accidents, assaults, can happen due to surgical instrumentation, especially esophagoscopy, and attempts to remove a foreign body, attempted strangulation, poisoning with corrosives, and due to the inhalation of fumes, so it can have burns in the throat. Gunshot injuries can damage the pharynx, blast injuries can damage the pharynx, even violent vomiting, and especially in alcoholics, can cause damage to the pharyngeal musculature. So the clinical features would be they will have severe pain in the throat and severe and very painful to swallow. Odonophagia will be there. And sometimes the pain may be in the interscapular region. Bleeding can be there from the throat, and they can have neck swelling and tenderness also. Surgical emphysema may or may not be there in the neck or mediastinum. Sometimes the pleural effusion might develop, and they might have septicemia a few days later. Diagnosis can be made with an indirect laryngoscopy or X-ray of the neck and chest, and with a barium or gastrography in swallow. We do not recommend to pass a upper GI endoscope or a rigid esophagoscope to diagnose a pharyngeal trauma because you can make the trauma worse. Management: needle by mouth, NG tube being had to be inserted for feeding, or IV fluids and IV nutrition can be considered with total parenteral nutrition. With NG tube cannot be passed. Antibiotics and analgesics, and if there's a pleural effusion, IC tubes might be required. In the early stages of presentation, might consider repair with the external approach. By the expression of the neck or by doing a thoracotomy can be repaired. But after 6 hours of the injury, then tissues are swollen up too much, it may not be possible to repair it. So we have to manage conservatively. So complication of pharyngeal trauma will be infections, septicemia, and pleural effusions. In the long term, there can be stenosis of the pharynx and strictures of the esophagus, and pharyngocuteus fistulas can also occur. This is the barium swallow showing a pouch in the esophagus. In the upper part of the esophagus, there's a pouch. So this is called pharyngeal pouch. And the problem here is because when the pouch gets enlarged, it might be pressing on the normal esophagus, so it will develop progressive dysphagia over a period of time. And the food can collect in this pouch, and then they might just come into the throat, so there can be regurgitation of the previous meal when you have a pharyngeal pouch. And some of these contents can spill into the trachea, and they might have a chronic cough and might even lead to aspiration pneumonia. So pharyngeal pouch should be considered in case of chronic dysphagia. Acute dysphagia might be due to the foreign body ingestion or an infection like Retropharyngeal Abscess or a pharyngeal trauma. Chronic dysphagia, one cause can be pharyngeal pouch. Of course, the malignancies in the esophagus can also cause dysphagia. So pharyngeal pouch occurs through a weakness in the inferior constrictor muscle called the Killian lesions. And the symptoms would be chronic dysphagia, regurgitation of whole food, chronic cough, choking, chronic aspiration, voice changes, and even a bad breath, halitosis. They might also feel a lump in the throat soon after the lump in the neck, soon after a meal. And they can manually empty that lump, and they might feel a gurgly noise in the throat when they do that. Treatment, either we can do a dilatation of the esophagus or division of the partition between the pouch and the esophagus can be done endoscopically, or external approach, and the pouch can be excised and cryptopharyngeal muscle divided, called cryptopharyngeal myotomy. Complications of surgery would be risk of infection to the mediastinum, mediastinitis, or recurrent laryngeal nerve palsy. If a person has recurrent neck abscess, especially thyroid abscess on one side, it is not enough to drain the abscess each time they present, but it's also important to look for a cause. Recurrent abscess in the neck, or especially in the thyroid, may be due to a sinus tract opening into the piriform sinus, connecting the thyroid lobe with the piriform sinus. So the infection tracks from the opening here all the way down along the tract to the thyroid lobe, where it causes the thyroid abscess. So nowadays, what we do is once we treat the abscess with IND in the neck or antibiotics, we try to seal off this tract. We use a monopolar diathermy and endoscopic guidance, and then burn it, and might do it several times, and then it might seal off the tract completely. So when the tract is completely sealed off, there is less chance of infection. There's no chance of secretion going down the tract and causing neck abscesses. Thank you very much.